Today we're going to be talking about cancer in patients that you'll be seeing in the hospital and across your nursing practice. This is Unit 4, Chapter 6 of Pellico, and you should be able to upload this on TigerNet. So first we're going to start off with the epidemiology of cancer. More than 1.5 million Americans are diagnosed with cancer each year. If you think about in relevance to how many people die of cancer each year, it's 560,000 Americans die from a malignant process in their body. Just a kind of a side note of how much that actually is, a lot of it's just numbers. But if we're looking at the population of Mitchell, and if we were to think of as a population how many people die of cancer each year, it would be around 25 to 30 people. So obviously not a lot compared to a 15,000 population, but in regard to how much in America get them every year, it's actually quite high. Cancer is accounting for more deaths than heart disease in people over the age of 85 years old. Over the age of 85, heart disease takes the toll because of the age and the process of actually getting older, and then people have more risk for heart problems. The good thing about cancer is that research is becoming more evident across the medical world. We're finding more ways to at least stabilize cancer, and actually there has been some trials and some research studies that some patients can get involved in, and those can actually cure cancer, but there hasn't been enough evidence out there that actually states that it cures the cancer for forever, essentially. So what does a cancer cell look like? Most cancer cells have a rapid or continuous cell division. Compared to a normal cell of the body, cancer cells progress at a very high rate. Anaplasia just means that the cells in general, if you can kind of see here, are different looking than the normal cells. They become kind of irregular looking, circular little areas, and the nucleus becomes very large. And so what that can mean is that it can produce a lot of cells in a short amount of time. As I said, you can see how the nucleus is actually getting bigger and the cells are actually getting smaller. Cancer cells don't serve any useful purpose in the body. So when these cells are actually produced, we can actually kill them and not feel bad about it because it's not actually producing any type of cause. And the way that some of the medications and chemotherapies, radiations work is by targeting the cancer cells because they are the most fast replicating, and that's how they target it. Whatever cells are replicating the fastest are what get killed. Loose adherence just means that these aren't able to stick to the normal sides of the cells here, and they're more likely to metastasize. Most of the time they lack that fibronectin that keeps that nice hold in place to the other cells, and it can actually dislodge into the bloodstream and cause metastasis to the rest of the body. So it kind of leads to our next topic of metastasis. The top places that metastasis can from cancer can actually go to are the bones, the lungs, the liver, and the brain or the central nervous system. You'll have to know this through and through because whenever we're thinking about cancer as spread, we can actually look at these targeted areas and hopefully look for the first lines of where they would go to. So if they're spreading to these areas, you can at least think that it's actually progressed stage of cancer, and we know that it's actually affecting more than just one localized area. The three types of metastasis are the lymphatic system, the hematogenous spread, and the angiogenesis. And how this works is the lymphatic spread. I'm sure you guys have heard of cancer where it spreads to the lymph nodes. This is what this means. It gets into the lymph node tract by an emboli from a tumor and can actually penetrate the lymphatic vessels. So if it's spread to the lymph nodes, we may have to remove lymph nodes or we have to do special types of treatment. The hematogenous spread just means by the bloodstream, pretty self-explanatory. Some new vascularity can go into the tumor, and that can actually make it spread. Angiogenesis just means that blood vessels are basically replicating themselves, and it's making new blood vessels into the tumor. So the vascularity actually increases in that tumor area, and it actually can produce the cancer to spread. So if angiogenesis is occurring, we can assume that the tumor is probably having high vascularity. This kind of shows exactly how metastasis works. You can kind of see here how this is the normal cells in your body. We kind of start off here that we know that there's some type of tumor or some type of foreign matter is involved in type of the cells. Here's just the normal bloodstream that actually is bypassing the cells here. So here's your interstitial space. Over time, you can get angiogenesis where these vessels, these new ones, come up into the tumors and it actually produces themselves, so then it's actually able to transfer. So here, if we look at our third image, here are angiogenesis already occurring, and it can actually slide itself into these new vessels and go into the bloodstream. And then in return, you have metastasis or migration of those cells, which is bad. So how do we get cancer? Well, no one really knows exactly. There has been a lot of research out there of how you can actually get it, but nothing really has confirmed it, except for we've looked at research studies of same processes and same people, and we have concluded that these are the top things we've found in cancer patients and what they've been exposed to. So chemical carcinogenesis, this is your tobacco, your alcohol, and your chemical exposure. These are the things that you've been taught since middle school or elementary. Don't smoke, don't do drugs, don't do alcohol, because this over long-term effects can affect your body. Physical carcinogens, you've heard of the tanning bed phenomenon, where you can get skin cancer, exposing yourself to that radiation that's not necessary. Over time, chronic irritation like sunburns, or if you are a burn patient survivor, you potentially could have cancer from irregularity of the skin. Viral carcinogenesis, this just means that viruses in the body can break down your immune system and over time break down your DNA strands, and this can also have you more susceptibility to cancer. Hep B and C and the papillomavirus, has been shown that it can cause cancer in the longevity of time because it's breaking down your immune system. Diet, I'm sure you guys have heard of this as well. We want to maintain a high fiber diet that we can have less red meat, less fat, and making sure that you're not eating processed foods. There's really no correlation to this aspect of it, except for that if you have a poor diet, you can have increase in obesity, which can in return cause high blood pressure, high cholesterol. These are things that we look for in cancer patients that may not help their immune system. Immune function, we talked about AIDS a little bit before last week, actually 2 weeks ago, and talked a little bit about how that can break down your healthy immune system, and that can make you more susceptible to opportunistic infections or cancer. Age, through and through, age is probably going to be the most important risk factor in cancer. So the older you get, the more exposed you've been to some of these processes and chemical irritants, and so we want to make sure that over time you're getting more screening done so you can actually, prevent or treat cancer early. Genetics, there has been some genetic studies out there that shows that breast cancer and ovarian cancer, types of women cancers, of course, have been linked to genetics. And so there are some genes that you can actually test for. And if they have those mutations on their genes early in life, we can suspect that they might have a higher risk for breast cancer or ovarian cancer. This is not done very commonly. It is very expensive. And it's not a diagnosis of cancer. It's just a higher risk because of you have that mutation. So the BRAC analysis is basically the test we talked about for genes, and it's going to give you the highest probability of having breast ovarian cancer. And so what is this doing? It's just letting the patient know that they have a higher risk and that they should be screened more frequently so then they could prevent a future problem from occurring. So we start here at our top here, and if you have a personal or family history of breast or ovarian cancer is probably when you would get this test. If you're worried that maybe a couple aunts, a mom, a sister had it, and you want to make sure that you're not getting it or preventing it. So HBOC just means a history of breast or ovarian cancer. It's a red flag, meaning that yes, you've had a history of it, or your family, has a history of it. If you go down here, they'll test for that BRAC, that's the mutation gene, and if the mutation is positive compared to being negative, we will have an increased risk for cancer of breast and ovarian, actually a pretty significant increase. And what we would do is we'd probably bring them into the clinic more often and make sure that they are getting their breast exams done at least every 6 months to 12 months, annual mammograms and MRIs, and also reducing the risk by maybe potentially giving medications. There are medications out there that have helped with breast cancer. If you don't have a mutation on that gene, we just will consider you the general population risk, which is great, which is a lower percentage. We would suggest that you go in annually for your breast exam and have an annual mammogram. The key number for mammogram is 40 years old. We expect everyone at the age of 40 should come in and get their mammogram. Most insurances will cover a mammogram for at the age of 40. So cancer prevention, we think about our 3 ways of preventing cancer: primary secondary, and tertiary. Okay, so the first one is primary, and how we're going to do that is we're going to avoid potential carcinogens. Obviously, if we've seen trends, we're going to prevent those from occurring. So we want to make sure that we're putting sunscreen on, avoiding tobacco, avoiding alcohol in excess, also avoiding asbestos exposure, which is like rat feces. And we want to make sure that you're being aware of your surroundings. If you have a strenuous job where you work like in a coal factory, are you being exposed? A farmer who has pollutants that they potentially might be spraying with. Diet, this is very hard in the Midwest because we have a lot of red meat, potatoes. We want to make sure we're having a good source of fiber in a low-fat diet. Decreasing the sexual partners and also safe sex. So if we're putting ourselves at risk for HIV or potential STDs, this can be lower on our immunity, making an increased risk for cancer. The at-risk tissues, so if you've had your moles or freckles looked at and something looks abnormal or potentially dysplasia is common in these types of moles, you can actually get them removed, and this can prevent cancer from occurring at a later date. Colonoscopies, very important thing as well at the age of 50 or earlier if you have signs or history of problems. If you have polyps, you can get those removed and hopefully prevent cancer. If there's one or two, they probably won't, take them out, but if they have multiple, they could. Breast removal, if they do suspect breast cancer or if you have a large breast, they might potentially take one or the other one off to prevent it. There has been something called chemoprevention, and what those are just a combination of medications that have shown to decrease the risk for certain types of cancer. Some research that I had found was aspirin and Celebrex. Those are two common ones that they use together if they have a history of colon cancer or family tendency of colon cancer. Vitamin D and tamoxifen have been shown to reduce breast cancer. This is not chemotherapy. This is just medication to help prevent that they've found. Lycopene to reduce prostate cancer has actually shown that too. Lycopene is found in a lot of like carrots and vegetables like potatoes, and so they actually have shown that prostate cancer has decreased over time. I don't know if you've heard of, is it mushrooms? Yeah, mushrooms. Mushrooms actually has lycopene in it as well, and it can reduce the prostate cancer risk. And then we're moving towards a more, modernized world where vaccination is becoming more apparent. And vaccination has actually, we found that Gardasil has a high risk for HPV prevention, and that can prevent that cancer from occurring. Secondary, this is probably going to be your most common. Obviously, everybody wants to prevent cancer, but nobody can be perfect all the time. So screening strategies we want to detect early and get them started earlier in life. If you know a relative that has not got their mammogram at the age of 40 or colonoscopy at the age of 50, highly recommend that they go in and try to get screened early. Like I said, mammogram at the age of 40 and colonoscopy at the age of 50. This is very important to prevent cancer from occurring. A PSA level, that's going to prevent any prostate problems from occurring. That should be at the age of 50 as well and should be done every year. Okay. We talked about the gene mutations linked to specific cancers. The BRCA is the risk for breast and ovarian cancer. Remember the diagram that we just looked at? Also, there has been linked to BRCA2 is increased just for breast cancer. So if they find a mutation on that gene in the body, they can suspect that there might be a high increased risk for breast cancer, but that's not conclusive. It doesn't mean you have cancer. Okay. The APC, MLH, and MSH2 genes are an increased risk for colon cancer. So there's different types of genes that we'll look for. It's just a matter of finding them and if there's a mutation. So we're going to look at how to classify cancer. I'm sure some of you have heard of stage 4 or the grade of cancer. Okay, we're going to talk about what that means and how it affects your prognosis and what it actually means to your patient. Cancers are classified at the type of tissue from which they arise. For example, hepatocarcinoma derives from the liver. Makes sense, right? The lymphomas, it derives from your lymphoids. Or osteosarcoma derives from your bone. Makes sense. Okay. The grade of a cancer is different than the stage, and what that means is that the grade is how the cells look in the body, like the abnormal cells of the cancer. If you have a nice uniform look to cells, and then all of a sudden you have this tumor process, and it looks abnormal, the nucleus is large, the actual cells are smaller, we're going to go by grade of how, ugly it looks. Okay, so the higher the number, the more tumor cells there are, and it's poorly differentiated. What it means is there's no normal cell characteristic. It's just random. It looks irregular. And then if it's G1, that would mean that it looks pretty similar to the normal cells of the body. It's just not to that process yet. So obviously G1 would be earlier stages in the process. If it's GX, that just means that it cannot be determined. Give it some time and it probably will be able to be determined. Staging is probably the most familiar that you are with cancer. It goes by the TNM classification, and what that stands for is the tumor, the nodule, and the metastasis. Okay, this is going to tell us exactly where the cancer is, how big it is, has it moved, and what is the prognosis. Okay, so we start off with clinical staging. This is when someone would present to the clinic, and we present it off an MRI or a CAT scan or potentially a PET scan. Okay, it's going to tell us exactly if you have cancer, and sometimes what it looks like, the size or how big it is, and potentially if it's spread. So if we've done an MRI to the brain or to the liver and we can actually see that, we could actually find that out. Okay? Surgical staging means that if they are going to remove the tumor, they can go in and see, physically inside your body what it looks like. Okay? So if we obviously open up your belly and we see it's on your liver, your intestine, your stomach, everywhere, we know that it's already metastasized. Okay, and then pathologic staging just means that we take a biopsy of it. It's the most definitive because we're actually getting the actual cells of the tumor, and we know exactly what it looks like underneath of a microscope. 7 warning signs of cancer. This is pretty general. Doesn't necessarily mean you have cancer, but it's just some suspicion of you should probably go get checked out. Changes in bowel or bladder habits are probably the most generalized, and they're probably least definitive. Just because you're having diarrhea or constipation or bloody diarrhea does not mean that you have cancer. It can mean that, but it is better to go get checked at maybe after it's been occurring for like a week or 2 weeks, okay? Just because you've had diarrhea for 2 days, don't go into the hospital or to the doctor and say, I have cancer, okay? Only when it's affecting your actual habits, like you're becoming dehydrated, that might be a reason to go into the doctor. But just for the sake of cancer, I would not get too suspicious of bowel or bladder habits until it's been occurring for at least a couple weeks. Okay, a sore that doesn't heal, obviously your immune system is affected, and so if you can't actually fight off the infection to heal a wound, that is an occasion to go to the doctor. Unusual bleeding or discharge for the woman, that could happen. Thickening or lump in the breast. If anything is new of a breast tissue, go into the doctor. I don't care if it's painful, painless, or it's tiny or huge. If there's a new lump in there that you're not familiar with or you have never felt before, go in and get checked out. Indigestion or of difficulty swallowing. Sometimes you're not producing the saliva and it can cause from like oral cancers. So that might be a reason to get checked out. Obviously a wart or mole change. I'm sure you've heard of ABCDE, where it actually describes the mole and what it looks like and how it changes. I'm trying to think of the borders. Sometimes if it's larger or if it doesn't look the same that it has, it grows in size. A nagging cough or hoarseness. I hear this quite a bit for people that have cancer. That is one of the first signs they had was a cough that didn't go away, and it wasn't accompanied by like a infection, like a cold. So surgery is probably one of the oldest forms of cancer treatment used for in the general population. And we've actually seen this over time because if you think about it, we have a tumor, get rid of it. Use surgery to get rid of the cancer process. Most common is a mole or breast removal. If we have a suspicion of skin cancer, obviously take the cancer out. Hopefully that'll affect it. If we need to get a biopsy of the entire tumor process or even a small portion of it, that would be an example of when to take out just a small portion. Debulking just means that you weren't able to get all of it out. For example, if it was on the spine, it might be kind of engulfed around the spine, so you might not have been able to get the entire process. So control. We're getting rid of most of it, so hopefully that will get it small enough so we can get the rest of it by chemo and radiation, but doesn't necessarily mean that we got it all, so it could still potentially grow, because tumor cells grow very quickly. So if we want to make sure we get it all, that's the only way to sure know that we got everything. Okay. Palliative, if someone is end of life and we're just trying to improve their quality of life because they're in a lot of pain, we can take out, tumors or, a kidney if it's causing a lot of pain in that area because the tumor has grown on there. We can take those out just for the process of helping them cope and also making sure that they're not having tons of pain. Reconstruction and rehabilitation. This is if you have breast cancer and you've had your breast removed, you could potentially have breast reconstruction. Or potentially if you've had bowel removed, you could maybe get the bowel resected. And also cancers of like testicles, if you need to put testicle implants in or penile implants. Radiation therapy for cancer. This is obviously hand in hand with chemotherapy usually, but radiation is going to be a direct source or internal source depending on how and what type of radiation you get. How this works is it destroys cancer cells and interrupts the cellular growth with minimal exposure of the normal cells to the damaging actions of radiation. So a lot of the things we look for is damage to the regular cells, and that's a lot of the treatment with radiation. We want to make sure that we actually see or know exactly what the radiation is doing to the body. Okay, it's used to cure, and it can be used to control the growth, or it can be used as palliative, just to shrink the tumor from occurring, so the patient's not in as much pain. Teletherapy is probably the most common type of radiation that you are probably aware of, and this is just the external radiation that you go into the big machine, and they put like a crosshair over where the tumor is in the body, and they do that 5 days a week for 3 to 4 weeks, and then they actually go exactly right where the radiation is being installed into the skin. They do the same place every single time. Sometimes it requires body molds to keep the body exactly in the spot that it needs to, so that way you're having the best outcome because you're actually hitting that spot directly every single time. Sometimes they do like tattoo markings where they'll put like a permanent marking on the skin so they can exactly know where the cancer is at. Brachytherapy is a short length of radiation where they inject it inside the body. The one thing I can think of is thyroid and also your prostate cancers. I'm sure you remember from our thyroid unit whenever they would actually put in liquid radioactive iodine, and that would eventually over time go away, but they were radioactive for a short while. Or if you think about prostate cancer, they inject these little seeds into the prostate, and they're radioactive. And they're not allowed to be around children and pregnant mothers, and they actually can't be around anyone for like a week. So they stay in the hospital for at least 5 to 7 days, and then when they go home, they aren't supposed to touch, really anybody, or when they're messing with their urine, to not touch anything. So here's the external beam radiation, or your teletherapy. You actually go into a machine. You can see them going in here. If it's cancer of the brain, they might have to wear this to keep their face exactly the right way, because if you smile wrong or something, or you're not exactly the way you were last week, you could potentially give radiation to a little bit different area. Even if it's a tenth of a centimeter different, it's still not exactly the same at what it was last week or the last day. Here's your molds that you see. It keeps their arm nice and straight and nice in the area that they want to. Here's the brachytherapy I talked about with prostate cancer. If you look at the patient here, they insert a rectal probe into the rectum here, and that's going to be basically a camera. It just shows where the prostate is so they can get a good picture. And they insert this needle right into the prostate, and what they do is they inject all these tiny little seeds of radioactive. And so what they do is they just stay in there, essentially, and shrink the prostate, and over time they'll get flushed out. Okay, so sometimes this can take up to 3 to 6 weeks, and they're in there for quite a while. Again, they're radioactive, so you shouldn't be sitting on their lap. You shouldn't be messing with their urine, and that is the risk they take by doing the brachytherapy. It's highly, suggestive of prostate cancer. It works really well. It's just there is some risk with it. Here's a video that you guys can see on TigerNet. I'm not going to play it just because the sound doesn't work on this computer. So I'm going to make sure that you guys can have access to it, and they will be inside your PowerPoints when you open it up. Okay, so radiation therapy obviously can have a toxic effect on the body. You can have skin changes and hair loss that will most likely be permanent depending on the total absorbed dose. Your skin obviously is in the path of radiation, so it's going to get very dry and can break down. But on the other spectrum, it can get wet and weepy, and it can get very edematous. Lots of redness can occur, almost looks like a sunburn if it's affected in that area, and it can develop anywhere from an hour after the radiation or up to a day. Okay, but most of the time after the first treatment, you are noticing a little redness or even dryness. Sometimes the skin can slough right off and kind of peel, And so we need to make sure we're having the best skincare that we can for these patients and letting them know what they can and cannot do, like using certain types of lotions, perfumes, making sure that they have the opportunity or the equipment they need to not have such a horrible outcome. Okay. Obviously, we need to make sure they're safe, making sure that they're not getting bed sores if they're in the hospital. They can have delayed wound healing because of the damage to that skin. Again, they can have kind of red spidery vessels, kind of like that redness tint to their skin. And also they could have scarring. Sometimes the skin doesn't grow back because there is like a scar tissue that builds up over the skin. Sometimes, like in uterine cancer, if they're getting direct radiation to the pelvic area, this can actually occur, have problems occur in the colon. And so that can cause scar tissue to build up and get constipation and potentially obstruction if the scarring is bad enough. Just shows a picture here of what you can kind of see over time with radiation. You can kind of see the acute effects after days to weeks. You get the redness, the dryness of the skin, and it does go more than just skin deep. After months to years, you can even see necrosis, gangrene, depending if your skin is getting circulation. It can disrupt those blood vessels in there, and it just depends on where it's at. The skin and the hair are pretty rapid acting cells, and those are similar to cancer cells because they replicate so quickly, and that's why they're affected. Most of the time, your body won't be affected if your cells are not replicating as quick as the cancer. It kills the quickest acting cells first. So just a picture of what radiation can look like. Obviously, this lady probably had cancer of the spine or central nervous system, and that's why she's having those areas. This is obviously after, maybe a couple of years, and it still has those effects, but this one looks like might have happened just yesterday. So what can we do as nursing staff to educate our patients to make sure that they're protecting their skin? We encourage them to clean their skin how they normally would with a mild soap. They don't need excess creams and lotions if they don't want them. There is some prescription lotions out there for radiations or over the counter if they're, not so potent on the body. We encourage just a warm water, not too hot, not too cold, and to use a pat dry method, not to rub the skin, because that can potentially open up the skin. We can do non-perfume moisturizing creams, but we do not recommend it 4 hours prior to the treatment because it could amplify the effects of radiation problems. We don't want to use any types of cornstarch if there's a yeast infection suspected, because that can actually make the infection spread even worse. If there is an open area or a wound on the skin, we want to keep the area dry and clean, making sure that no infection is spread. We want to have a nice loose clothing to make sure that there's no irritation or something pushing on it, like a belt, buckles on shoes, straps, bra straps. Sometimes we encourage patients just to be in comfy clothes after and before radiation. If there is radiation to the skin, we encourage to have no exposure to the sun. To make sure that we're having no added burns to that area. We don't want them to swim in salt water like the ocean or any pools because that could be irritant to the body. And also we're going to avoid shaving or using types of deodorants or perfumes in that area that's being affected. Obviously, if you have skin cancer of the toe and you're putting radiation down there, you can still put deodorant on your body. It's just not in that area. If there's any type of tattoos that they use for marking to make sure the radiation is there at the same time every radiation treatment, do not remove any of those markings because those can be what help them guide them to make sure that they're having their same radiation in that spot. GI problems that you can suspect to occur in radiation. Sometimes anorexia will occur. This can occur around week 4 and tends to disappear when the treatments are being finished. So once the radiation is done, usually your appetite comes back. We encourage them to eat small, frequent meals, bland, nothing too spicy, nothing too sweet, something that's easy to swallow. Sometimes they don't secrete the saliva that they used to. They have very dry mouths. Obviously increase in carbohydrates and proteins. We want them to get the most amount of nutrition in the smallest manner because they're not going to have big appetites. Megace is also something to increase appetite. That's what I told you about. It's like a medical marijuana, and that's going to help increase your appetite over time. They'll usually start that early in the radiation process or before to make sure that you're not having problems with malnutrition. Mucosal epithelial is actually lost in the first 1 to 2 weeks, so they can have a lot of dry mouth. You'll hear a lot of patients getting sores in their mouth or ulcers on the tongue, and so we want to make sure we're keeping them nice and lubricated in their mouth. We can give them artificial saliva like Saligon, and that's used probably 2 to 3 times a day. I think is it's kind of like a spray for your mouth, but it's not really a medication per se. It's just kind of a moisturizer. It helps you make your saliva in your mouth. Obviously, taste loss. You might not have the taste buds you used to after the treatments. I've heard of a lot of cancer patients never getting their sweet taste back, and everything tastes kind of bland. You can get irritation of the entire GI tract from your mouth to your throat to your stomach, and you can actually use types of medication like antacids like Mylanta to kind of calm down those acids in your stomach. Benadryl has been found for anti-inflammatory. Viscous lidocaine is like an oral, it swishes in your mouth so it keeps it nice and moist. Carafate is going to be used for like if you have gastritis, and it just coats the stomach really well. We're going to avoid lemon and glycerin swabs. If your patient is complaining of dryness in their mouths, please do not give them any type of flavored or glycerin swabs during their treatment if they are there for cancer. It can actually cause more irritation and it dries it even further. If a patient's having frequent diarrhea, because that can happen from the radiation as well, we can give them Questron, which is just going to bind to the bile salts, and it's going to give you a better consistency of stool, so it's more hard rather than like very loose. Okay, and that'll help your rectal area not break down as frequently. Anti-emesis meds can be given 1 hour before treatment. Those include your Zofran, your Compazine, and your Phenergan. We want to make sure that with every GI problem that they can get, we want to make sure that the nausea medications are given for sure before any type of treatment, because we want to prevent it. Even if they don't get nauseous, we want to make sure we prevent that, because if they're having MSS when they're anorexic or they're malnutrition, we want to make sure we're preventing that so they're not having problems with nutrition and getting their food down. Here's a picture of what you can see for breakdown in the mouth. The mucosis, of the skin is not actually intact, and it can get from a mild to a moderate. You can kind of see like the little areas of holes right there. Okay, so reproduction. Sometimes reproduction after the radiation, especially in the pelvis area, can affect their fertility. 95% of females have permanent amenorrhea, where they don't get a period anymore, and can potentially cause them to be infertile. Usually it comes back after 2 to 5 years, or potentially not at all. So we want to give our patients realistic expectations so they know exactly what can happen from radiation in that area. If they're getting exposed to radiation in the chest area, they could have alveolar collapse, where scar tissue builds up in the lungs, and it can actually cause problems with breathing. Potentially a cough can persist, and it can require O2. Okay, so our other type of treatment that we're going to use in cancer is chemotherapy. And they can treat cancer, obviously. It promotes cell death by interfering with cellular function and reproduction. It's a major role in cancer therapy. Most patients will receive chemo at some point or another if they have a diagnosis of cancer. It can be used to cure, or it can be used to control the cancer from increasing or replicating, and it increases your survival time. It makes patients live longer, even though they might have more side effects, but it actually over time kills the cells from replicating. Normal cells divide at a less rapid rate, and so that's why they're not affected by the chemo as well. Chemo goes directly to the cells that are replicating the fastest. So sometimes it can affect your skin and hair, and also like your sperm count and your blood forming cells. And so those are the reason why those are the top side effects of cancer, because that's why they're affecting from the chemotherapy. So you will lose your hair, most likely, on your skin as well. You'll have irritation, dry skin. Sometimes you'll be infertile, and then also your white count, your red blood cells, you'll become anemic. Those are things we look for in chemotherapy patients. And most of the time, chemotherapy, you're going to get more than one medication. You're not just going to get one chemotherapy and hope that one works the best. You'll probably get a combination of a couple to make sure that it's working properly. Again, this video is located on TigerNet. I'm not going to play it, only for the fact that the sound doesn't work, but it is located on TigerNet in these PowerPoint slides, so just take a look at that at your leisure. Chemotherapy drugs used for cancer patients. I am concerned about the side effects of these chemotherapy drugs, but in general, a nurse has to become certified to be a chemotherapy nurse. I'm not saying that you're not going to come across a couple of these medications on the NCLEX, because you might, but I think what they stress on the NCLEX is the top things that you're going to do for nursing care with these. For the test, I'm not going to require you to know the action or the drug class of each of these medications. I expect you to know I would say the top 5 side effects of chemotherapy drugs in general. So I'm not going to stress on exactly all of these medications unless I, start talking a lot about certain one. But for the most part, I'm just going to focus on the side effects. Okay. So chemotherapy, there is a special technique that you use for administration. They do gown up really well. They put a shield on to make sure the chemotherapy doesn't spray in their eyes. And also their patients are probably immune compromised. And so they want to make sure they're not injecting or introducing any new bacteria or infection into their ports that the chemotherapy is going through. So we want to make sure we're preventing complications, and we want to make sure that we're observing the whole body so then we can, treat any of the side effects that might be common. Some patients may not be as verbal as others, but we would do a full assessment every single time, like a mouth assessment inside to make sure there's no sores. So then that way we can help them too. We're probably going to do daily weights to make sure they're not losing too much weight from the chemotherapy and radiation-induced anorexia. Okay, we want to make sure these patients are safe and making sure that they are having good management of side effects. Like I said, we are going to look at the top 5 side effects of chemotherapy medications, and that's what we're going to focus on in nursing care, because that's what you're going to be doing as a nurse if you're not an actual chemotherapy nurse. If you are a chemotherapy nurse, you will go through a special class to basically memorize all the medications and what they do. But I expect you to look them up in clinical if you've never given one before. Chemotherapy is very potent on the body, and most patients will get some type of irritation on their skin, but if they go into an inflammation state where they're getting flushed or have a rash or anxiety, sometimes we will stop the infusion and give them other medications to lower the risk of inflammation, and then we can restart it. But other times, if this is occurring every single time they're getting it, they might have to change their chemotherapy. Extravasation is when you have an actual chemotherapy going through the hand or a peripheral area and it actually gets infiltrated. And so this is why we check this frequently during IV medication administration, but especially during chemotherapy. You'll be watching at least every 15, if not more often, minutes to make sure that they are not getting extravasation. What we're going to look for in patients that potentially could have early effects of this, they're going to have a lot of pain around their IV site. They're going to have no blood return, usually, swollen. It's going to maybe be weeping or have blisters around the area, and it's going to be really cold because the circulation is poor. So if we notice these signs, we potentially would stop, well, we should stop the medication or the chemotherapy medication, and then give the antidote. And what that is you take back all the remaining drug that's in like the little piggyback, and you would take the IV out, and then you would put the medication like right next to the IV site to hopefully reverse these effects. And there's certain medications that reverse the effects of chemotherapies. Obviously, you need a doctor's order for that, so you would call the doctor as soon as you figured out that there was extravasation. We want to elevate the site to produce less swelling and to apply cold and warm compressions. So we start with probably warm to get the circulation good, and then cold for swelling. And then it's based on patient preference too. If they're having a lot of pain, we just give them the option. We're going to observe for necrosis, ulceration, and they might potentially need a skin graft if it's this bad. We would obviously want the patient, if they're getting chemotherapy, to inject or to introduce a central line portacath or a Hickman catheter, because those are going to be central lines and have less risk for infiltration. So some more side effects. Chemotherapy, obviously nauseous and vomiting. Like I said, I want you to know the top 5 side effects of chemotherapy, and this is probably at least number 2 and number 3 for top side effects. So like I said, administer antiemetics 30 minutes to 1 hour before chemotherapy and on a schedule. We don't want to get behind and then they're puking for 6 hours because we couldn't get ahead of it. Cisplatin can induce delayed nausea and vomiting, so we want to continue this 5 to 7 days after the chemotherapy has been started, and so potentially we could start this before the chemotherapy starts as well. I have listed all the drug classes of what the medications are. The serotonin antagonists, these are going to block the serotonin receptors of the GI tract and the chemoreceptor trigger zone. These ones are pretty common, you probably have heard of. Zofran is probably the most common, and that's probably what I would test over. Kitril and Dalastron and Polanositron are common ones that not as common ones that I have not administered, but they're more specific to chemotherapy patients. Okay, and then you have your Reglan, that's pretty common as well. And those are your dopaminergic blockers. And how they work is they block dopamine receptors of the chemoreceptor trigger zone. And Reglan is one of those ones that keeps your GI motility going, so then you're not backing up and having emesis. Your neurokinin receptor antagonists, this is like your Emend. These are specific to chemotherapy patients because they work really well with the receptors of the neurokinins. Anticholinergics is like your Dramamine. Antipsychotics have actually shown to have to show that it does have some effects with nausea and vomiting, so they can be used for both. Compazine and Trilofan have been used to change the chemicals in the brain, and it actually shows reduced risk for nausea and vomiting. You can use a number of these, one of these, or a combination with corticosteroids, sedatives, antihistamines, depending on what type of medications work the best for your patient. Skin breakdown or mucositis is going to be like a breakdown of this oral mucosa. And it can happen anywhere in the GI tract, anywhere from the mouth to the anus. And so we look for those on full assessments. And we're going to look for sores in the mouth, painful, irritant sores that are very, very painful. This is going to make them not want to eat. On top of it being sore, they're not going to want to, they're going to be very dry, so nothing's going to taste good or even be able to be swallowed. If the patient is willing to eat anything, we allow them to eat whatever they want as long as it's not irritant to their skin. But if they are hungry, let them eat. We just want them to get nutrition. We want to keep the skin clean and dry and also maybe produce more lubrication in the mouth. So we can give them saliva production medications or even just giving them normal saline every hour in their mouth. We'll use soft bristle toothbrushes. We don't want to give them any type of dental floss because we don't want any increased risk for bleeding. Every hour at least, or every 15 minutes would be ideal. They could swab their mouth out, making sure that they're getting some type of saline in their mouth. We can provide antacids or analgesic mouthwash, and they can kind of swish it around their mouth, and that'll hopefully prevent any infection from occurring. And then obviously we're going to monitor their daily weights, and we can look at labs too to see how their nutrition is progressing. So their albumin and their prealbumin is going to be a direct indication of if they're eating well and if their nutrition is adequate. Cardiopulmonary toxicity is another common side effect. This is obviously a chemotherapy agent, Adriamycin, and it can cause irreversible cardiac toxicity. So if this chemotherapy agent is given, we look for certain types of problems with the heart. We usually get a baseline EKG and monitor for signs and symptoms of congestive heart failure. This is just going to be things we look for with this type of medication, not necessarily all chemotherapy agents. But we do have on the back burner that some of these can be cardiotoxic, so we want to make sure we're watching heart function and also pulmonary function. Hair loss is probably one of the most common ones that you probably have heard of or know about. It can be the whole body or it can be just the head. So we look at hair loss as a temporary thing for the patient. We let them know that it can be temporary, but it can regrow over time, but it probably won't look the same as it initially was. So if you had blonde, straight, as a bored hair, the next time it might be a thicker texture, it might be a totally different color, and it might be patchy. It might not grow in nice and thick like it was before, or nice and thin if you want to have thin hair. We do encourage them to get wigs or scarves, but like I said, the hair loss is temporary. So maybe the wig can be just for a year or two, and then once they get their normal, well, once they get hair back, I shouldn't say normal, but once they get their hair back, they can style it the way they wish. Coping is a priority. These patients are very disturbed when they find out their hair is falling out, and it can be very scary for a lot of these patients that have never had to go through this process before. Fatigue is going to be probably one of the most commonly reported side effects. They're always tired, they have no energy. Usually develop this in the 3rd week of treatment, whether it's chemotherapy or radiation. They can have their white blood cells, platelets, or red blood cells decrease. So if you're anemic, you have high risk for fatigue as well. So we just want to make sure that they're getting the activity they need, but also having adequate rest. So frequent alternate activity with rest periods. Walking has been the best thing, is in, releasing endorphins, making sure that you're getting the exercise you need. It actually requires them to do a little more, but in the end, they actually have better outcomes and they feel a lot better. Making sure they get the sleep they need, having sleep schedules. If they are still working, this might be very difficult, but they may have to take frequent naps as well. Small, frequent meals, if they are able to eat, let them eat, because they're going to eventually lose weight. So the best thing to do is introduce high-calorie meals that have lots of protein, and then potentially they might need supplements as well. Physical therapy, it would be if they over time got so fatigued and weak that they needed assistive devices to get moving, and also just to get like passive range of motion, active range of motion to get going. Myelosuppression just means that your chemotherapy is destroying the circulating blood cells, and it reduces replacement of these cells by suppressing the bone marrow. So what you can result is leukopenia, which is your decreased white blood cells, also called neutropenia. And if you're going to be reducing white blood cells, you have a high risk for infection. So we will institute neutropenic precautions. And what that is we put them in a designated, isolated room, and we try to limit their visitors and try not to have flowers in the room, anything that could cause bacteria, or make sure their food is well cooked. Making sure that they wear a mask or family members wear a mask if they're around their family member that has cancer. Just limiting any type of infectious process that could develop. Anemia is obviously decreased red blood cells. You could potentially have hypoxia, fatigue, dizziness, or hypotension if you have a severe anemia. So we will be monitoring those labs and also vital signs more frequent in these populations. If you do have a decrease in red blood cells, we could give certain medications like blood, and there are a couple other ones that we'll discuss in a little bit that help with red blood cell production. Thrombocytopenia, that's another myelosuppression side effect. You could have low platelets, and so if you have low platelets, you could potentially bleed because you don't have those platelets to actually clot, and so if you bump into a table, you might bruise more easily than someone that doesn't have low platelets. And of course, hypoxia and fatigue, because you're not actually producing the clotting factors. You also could have a decreased protective or immune response. You have a very high risk for sepsis, because if your white count's very low, you could potentially have a high risk for getting an infection. We want to manage our infection risk with the biological response modifiers. And what those are is, we'll talk about those in just a second. What they are is they modify the patient's biologic response to tumor cells. And so what they do is they're just a fancy word for helping the immune system and making sure that they are preventing any infection from occurring. Okay, so it's going to trigger that these biologic response modifiers be given throughout the body, and it's going to hopefully destroy the infection process. Okay, we've actually invented synthetic BRMs in the body, and so we actually can give medications to help the BRMs to occur. So some types that we're going to talk about that you see a lot in cancer patients. The first ones are the interleukins, and what they are is a group of 37 substances that the body makes to help regulate inflammation and immune protection. And what they do is they basically produce more of the immune cells so they can go and kill the abnormal cancer cells. Okay, we do make synthetic versions of interleukins, but interleukins usually are found in the body. We just produce them when there's an infection present. Interferons, this is going to work by preventing cancer from occurring. So if you have normal cells, this is going to protect the non-infected cells so they're not getting the virus. Okay, so it's going to slow the tumor cell division and hopefully prevent it from spreading throughout the body. Okay, so you hear interferon given to people with cancer or with viruses that they don't want it to spread so quickly, and it won't kill the infection they currently have, but it'll help it for preventing more. Okay, the third one is colony stimulating factors, also known as growth factors. These are like our synthetic ones that we made, and they can actually be given with chemotherapy, potentially because chemotherapy is what's causing these problems. But Neupogen is a common one that can be given IV or sub-Q, and that treats neutropenia. If you have low white count or neutrophils that are low, this will increase it, so then hopefully we won't have high risk for infection. Erythropoietin, also called Epogen or Procrit, can be given IV or sub-Q as well, and this is going to treat your anemias if your hemoglobin is low, and also if you have a high risk for bleeding. Aranesp is pretty similar to erythropoietin. It's going to work the same way and increase your anemia levels, making sure your hemoglobin is stable, your red blood cells are stable. Your Numega is also going to be kind of the synthetic version of interleukin, and it's going to stimulate the bone marrow to make platelets. Okay, so it's going to treat your thrombocytopenia. Some side effects of the BRMs, you could have potential edema in the tissues or even in your organs. You could potentially have brain edema as well. We could have orthostatic hypotension, where you monitor blood pressure pretty frequently, and you don't want to get these people up too quickly. You could get fever or chills, and we would prevent this with acetaminophen. Sometimes they give that a couple times a day just to prevent any problems from occurring. Demerol has been pretty commonly shown to reduce chills, and this is resulting exactly from your BRMs being given. It's going to have a toll on the neurological effect of the body, and that can cause your body to go into chills. These people might feel very weak and tired, have flu-like symptoms, flu-like fatigue, where they just constantly are trying to sleep all the time. They could have some peripheral neuropathy, skin problems, dryness of the skin. All these are related to your BRMs. Leads us to the next problem with cancer, and that could be pain. Pain is a very common problem with cancer because the tumors can be pressing on certain areas of the body. The one that I'm thinking of is cancer that could potentially be in like the bones. Bone pain has very common effects with cancer. We usually try to start them in the step 1 process, where we don't necessarily start the hardest medication that they can have or the most severe. We start them off with a non-opioid. So this could be like an anti-inflammatory. It could be like Tylenol, something just to kind of take the edge off. And then we could also add or eliminate an adjuvant, and what that is they will get something that, like say if they are getting Tylenol, they might get aspirin as well. So they can get a couple different medications that's not technically an opioid, or if they're having peripheral neuropathy or different types of pain that can be given with different types of medication. The next step would be, if their pain is not controlled, is an opioid, and we'd use a mild or moderate opioid. No, we wouldn't use a severe until we knew that the pain was not being controlled. So again, we could use an opioid, we could add a non-opioid, and we can also add an adjuvant, which would be kind of like a for peripheral neuropathy. So you have nerve pain medication, you could use a Tylenol, they just have a non-opioid, and then you could also use a mild narcotic. Okay, let's say the pain is still persisting and they have cancer and it's progressing throughout the body. We would move to a moderate to severe opioid, and then we could inject or introduce these other ones as well. Okay, these medications will be giving around the clock. You will not give them PRN. We might start off with a very low dose if they're not having a ton of pain, and making sure that they're getting it frequently, because we want to prevent any problems from occurring, as long as they're, mentally intact, they're not lethargic. But as long as we are having effects from these medications, we're not going to switch them around. So oncological emergencies that you can see from cancer, you're going to see different types of problems occur in these populations over time, and this is what nurses need to be aware of early in care, so then we can actually prevent some of these from occurring. Sepsis is a thing that we probably have talked about the most, because a lot of problems can derive from sepsis. We'll learn about it more in the spring, but for what I want you to know about for this test is that it can occur, and we'll kind of talk about the basic principles of sepsis. So sepsis is just an infection. It can derive from the bloodstream, the urine, the lungs, just depending on where it's coming from. It's due to a low amount of white blood cells and an impaired immune system. Things you can probably see in a severe sepsis patient are hypotension, tachycardia, increased respirations, sometimes a fever patient depending on if you have an active infection. They can in return have a level of conscious change and can lead to organ failure or septic shock. The main priority that you want to do in sepsis is get blood cultures so we know exactly what infection is occurring, and then we're going to start IV antibiotics and potentially get fluid boluses if they are hypotensive. So there was a Surviving Sepsis campaign, and what they did was they had a time frame for all these things that have to be done in a septic patient or a suspected sepsis patient, and the most derivative lab that they found was a lactic acid or a lactate level, and this is going to show us exactly if the patient's septic. So if their lactic level is greater than 2 or potentially greater than 4, you will have an active septic patient. Okay, so if the lactic acid is elevated, we'll obtain blood cultures and probably give a broad spectrum antibiotic until we know a little bit more about the infection, which could be a couple days, and then we would have a more specific antibiotic. We would administer fluids because these people are most likely going to be hypotensive, and then we want to make sure that if their fluids are not working or if they're congestive heart failure or have fluid overload, we potentially might have to start vasopressors. And this is going to be for hypotensive patients, and we want to maintain a mean arterial pressure of greater than 65. So we know that their whole body is being perfused, so they're not going to have MODS, which is organ dysfunction. Okay. We potentially might insert an arterial line, and that's going to measure your blood pressure directly all the time without having to take a cuff pressure. Your central venous pressure, do you guys remember that? That is when you inject a central line in, and it's going to measure your fluid status. The higher the number, the more overloaded you are. The lower the number, the more dehydrated you are. Okay. Oxygen status, we want to make sure that we're watching their oxygen levels. So that would show us in the central line as well. Again, lactic acids can be drawn probably at least every 6 to 12 hours to make sure that our therapies are working. DIC is derived from sepsis. Usually disseminated intravascular coagulation does not just occur on its own. It's usually occurring from some other process like sepsis. Sepsis causes DIC. And what happens is when your normal clotting processes are activated and systemically and it uncontrollably grows. So you're having a large amount of clotting processes going on, so your clotting cascade can basically not stop because it's producing so many thick mucousy blood. And you have a high risk for blood clots in the beginning of DIC, but over time your clotting factors get all used up and your platelets essentially run out. And then you can have a high risk for hemorrhage. So initially you have a high risk for clotting, and then as it progresses you use up all your platelets and you have a high risk for hemorrhage. Okay, so initially we might use anticoagulation medications to help your blood stay thin, like heparin, and then over time we would want to give medications to stop the bleeding. Okay, so this is a very touchy problem, and we want to make sure that we know exactly what state of process that it's in. Okay, so the best thing to know is identifying this early. We want to make sure that our labs, like our PT, our PTT, are being drawn, and also our platelet level. You'll identify in the early stages that these problems probably are less. You might not have bleeding in the beginning, but later these could be increased. So we want to treat this very aggressively. Initially, we would start off with sub-Q heparin, not IV, just sub-Q. And what it's going to do is it's going to slow the cascade of events that makes the body overuse blood clotting factors. And then if we get to that problem where you're bleeding profusely, we would actually give clotting factors, and then we would make sure hemorrhage is not the problem. And if you were bleeding, you potentially might need red blood cells. Superior vena cava syndrome. What this is when there is a tumor process that is obstructing the superior vena cava, and this can lead to a lack of blood flow to your head or neck or upper trunk region. You will not see effects in the lower parts of the body, just the upper parts. This is a life-threatening emergency. What you can see on the patient here on the right is that they have a lot of swelling, and they can actually become obstructed because it's pressing on that superior vena cava. The Stokes sign is the tightness of like the skin there. You can see it's elevated. You can see all these veins or these it kind of gets red in that area as well, but also swollen. But you have engorged blood vessels that are proven in this area. If you do see this in a patient that you know has cancer, obviously call the doctor right away. Late stages would be cyanosis if they're turning blue or their circulation is poor or they're hypotensive or hemodynamically unstable. These are things that would be late signs, and we'd have to make sure we gave medications to help prevent this, and I'll tell you about those in just a second. So here's what it looks like. Here's our superior vena cava, and you can see here that the tumor is all around here, and eventually they grow and it compresses that superior vena cava. Okay, so the tumor is usually widespread throughout the body. It doesn't just develop on the superior vena cava. So if it's during this process, we can suspect that there is metastasis and that the cancer has spread. So the treatment for this is going to be very high dose radiation therapy in the upper chest. We're going to give a high dose corticosteroids to reduce that swelling, so then you're not being obstructed and not having hypoperfusion. Potentially, if those two do not work, we will do surgery to put a stent inside the superior vena cava, and that's just going to open it up so our circulation is not cut off. Spinal cord compression. What this is if you have a cancer of the spine, you can have persistent back pain in a localized area. So patients that doesn't necessarily have to have spine cancer, but could be spread to the central nervous system. And if patients are complaining of increased pain, they can have a suspicion for spinal cord compression. Some things that they can observe would be numbness or tingling in the lower extremities. They could have very weak legs in the lower extremities. They could have tingling, loss of bowel or bladder problems. Usually it's lower than where it is in the spine. Our treatment is often palliative, meaning that these patients are in a lot of pain, and we usually would do like a radiation or corticosteroids to reduce the swelling and to reduce the size of the compression. And this would eventually give them less pain. If that is not working, we can have surgery to go and remove the tumor altogether. But like I said before, this is a difficult area to take off all the tumor, so they might not get it all, and it could potentially grow back. Okay, there has been a couple of braces that they've been able to use to kind of relieve the pressure, but sometimes these don't work very well. Hypercalcemia, we talked about this in our previous units, and what this is obviously our calcium in the blood is very high, and it's direct related to bone metastasis. Okay, this is pretty familiar to you guys. Tumors are released from the parathyroid hormone. Tumors release parathyroid hormone, some tumors that are in that area, or you could have tumors around the parathyroid. Some early signs and symptoms, these people might be very tired, they don't eat very much, they could be nauseous, vomit, have some constipation, and also they pee a lot. Over time, they'll get severe muscle weakness, and if you think about this, the higher calcium you have, the less tetany you would have in the body. If you're hypocalcemic, you can have tetany where it contracts. So if you have hypercalcemia, you won't contract, so you'll have muscle weakness. You also would have loss of deep tendon reflexes, makes sense, because you're not contracting. And then you could also have EKG changes. So what we do for these is keep these patients very hydrated and making sure they're getting normal saline through their IV. And this is going to prevent any like stones from occurring. Sometimes when you have a high amount of calcium in your blood, you could get kidney stones. So hydration is going to be key. They might potentially get calcitonin. Remember that hormone that's going to be able to decrease the calcium in the blood. And also mithromycin is another one that regulates calcium levels. Also remember when we talked about calcium and phosphorus, the higher calcium you have, the lower phosphorus you have. And it works as a teeter-totter effect. So if we give biphosphonate, or also Fosamax, that's going to actually increase your phosphorus levels, and it's going to decrease your calcium levels. So that works really well for hypercalcemia. Pericardial effusion or cardiac tamponade, that's another one that we talked about in Unit 1. And remember, pericardial effusion is just accumulation of fluid around the pericardial space, and it could lead to a cardiac tamponade. Okay, so that's fluid compressing the heart, and the heart's not able to adequately pump. Okay, we diagnose this through an EKG. Sometimes they can see ST elevation, a chest X-ray, and also a CT scan. So if you see this and the doctor knows it, they're probably going to do a emergent pericardiocentesis. This is when they put that huge needle into their pericardial sac and aspirate the pericardial fluid. Okay. They also could do radiation after this to prevent it from reoccurring. And then pericardial window is pretty much the same thing as a pericardiocentesis. It's just going to work a little better, and it puts a little shunt in there, so then it drains better. Some signs and symptoms of a pericardial effusion. Obviously, if your heart's not being been able to pump effectively, you could have shortness of breath. You could have blood pressure problems, hemodynamic instability. You could have distant heart sounds, and also you could have like a rub or a gallop. SIADH, this is going to be from what we learned about last unit. It's the most commonly found in carcinoma of the lungs, and you can also deal directly with tumors on the brain. So obviously the SIADH is when you're producing too much antidiuretic hormone. So if you're producing too much antidiuretic hormone, you're not going to be peeing as much, and it's going to retain a whole bunch of fluid. Okay, so most of these people are going to have retained fluid, fluid overload, edema, low sodium because it's dilutional hyponatremia. And so these people potentially might have symptoms of low sodium levels. So you could have muscle cramping, loss of appetite, weight gain, especially if you're retaining a whole bunch of fluid, level of conscious changes, personality changes. In the end, you could have seizures and even death. So we're going to limit the fluid on these patients, making sure they're not getting overloaded. We're going to increase their sodium intake if their sodium levels are low and they're having symptoms from it. We're going to give them declomycin, which you need to know, is going to inhibit the ADH secretion. We talked about this in Unit 3. This should be kind of a review for you. And then that's going to also promote the water to be excreted. The reason why we'd give hypertonic 3% saline over normal saline is that, one, your sodium level is very low, so we want to make sure we're giving 3%, but also 3% is not given as quickly as normal saline would be given, and you don't get all the extra fluid. Hypertonic solution, you'd be going at like 30 mils an hour. Normal saline, you go at like 150 mils an hour. So what this is going to do is we're going to get a less amount of fluid, but a higher amount of salt. So this is actually better for these patients. Tumor lysis syndrome is going to be when you get chemotherapy or radiation-induced cell destruction. So a lot of the cancer cells have a high amount of potassium, phosphorus, and nucleic acids because they're replicating so quickly. So they have a high level of these electrolytes. And so what they do during radiation and chemo is they burst because they're being killed, and that releases into the bloodstream and can cause your body to have electrolyte imbalances. So the kidneys can no longer excrete the large volumes of all these electrolytes, and potentially you could have problems with your electrolyte levels. So obviously we're going to look at our electrolytes. Uric acid could be high, phosphorus could be high, and your potassium could be high. But calcium will be low because your phosphorus was high. Okay, so those are things that you can find throughout your cells. Some signs and symptoms based on electrolyte abnormalities. We want to make sure that we are measuring your electrolytes frequently, and then if you have a high or low one of these labs that we're fixing it and making sure we're giving medications to reverse it. Okay, so that concludes our PowerPoint for today. If you have any questions, you can email me. We will continue with lecture on Wednesday.